Hi guys, it's me, Professor D, and welcome back to my channel. On this video, I'm going to be covering lab values. I know a lot of you guys have trouble with those numbers and the values and what it means. So I picked out the concepts that I see show up the most, concepts that you definitely need to know for testing purposes. Okay, if you haven't done so already, please don't forget, like, comment, and subscribe below. So let's get started. A client with congestive heart failure is about to take a dose of furosemide Lasix. Which of the following potassium levels, if noted in the client's record, should be reported before giving the due medication? 1, 5.1, 2, 4.9, 3, 3.9, or 4, 3.3. If you're new to my channel, guys, go ahead and pause after I give the selection choices if you need time to think of your answer. Okay, guys, so the correct answer is D, 3.3. So I want you guys to understand this concept. It's very important for you guys to know. First of all, the therapeutic range for potassium is 3.5 to 5. 3.5 to 5, okay? And most lab values, they differ in a point or two, but potassium 3.5 to 5, that's universal anywhere you go. And the reason for that is because the therapeutic range is so narrow. Anything outside of that 3.5 to 5, that patient's in big trouble, especially their heart, okay? So one of the important things for you to know, potassium level 3.5 to 5, all right? Second thing, so we're talking about furosemide, we're talking about Lasix. That L in Lasix stands for losing. Patient loses potassium, all right? So this diuretic Lasix, which makes the patient urinate, they're losing a lot of potassium in the urine. So before you give a patient Lasix, you want to look at the potassium level. Now let's look at these choices. 5.1, 4.9, and 3.9. Let's start with the first one, 5.1. That's high, right? But guess what? We expect it to be high. That's why we're giving the patients the diuretic. We want them to get rid of the fluid. And the L in Lasix is going to make them lose potassium. So it's going to bring the potassium down. So we're not going to call the doctor or hold the med before we give that med. We know the Lasix is going to do its job and bring down that potassium. Choice number 2, 4.9. That's within normal range. There's no reason for us to hold the medication or call the doctor. Choice C, 3.9, that's within normal range. Remember, I told you the normal range is 3.5 to 5. Now, the correct answer, which is choice D, 3.3. Whoa. 3.3, that's below the therapeutic range. So if this patient's potassium is 3.3 and you go ahead and give them Lasix, which makes them lose potassium, that patient's in trouble and you did it. You're going to throw that patient, most probably you're going to throw them into a dysrhythmia, okay? So if you're giving Lasix and you see that potassium is less than 3.5, you're not going to give it, and you're going to call up the doctor and say, hey, I noticed you ordered Lasix, but this patient's potassium is less than 3.5. Are you sure you want me to give it? And if the doctor says, yes, I want you to give it, you tell them to come down and give it themselves. Listen, guys, I tell my students this all the time. When you know your stuff, there's no reason to be afraid of the doctor. I see this all the time. Nurses are afraid to call the doctor. They're afraid to question an order. You better question that order if your license at risk, okay? So anyway, 3.5 to 5, Lasix makes you lose potassium, and you always want to check that potassium level, obviously, before you give it, okay? Next question. A client went to the emergency room with sudden onset of high fever and diaphoresis. Serum sodium was one of the laboratory tests taken. Which of the following values would you expect to see? A, 130, 2, 148, C, 143, or D, 139? So guys, the correct answer is 2. 148. And guys, I'm sorry. I know these are letters and I keep doing numbers. I don't know why my brain is switched like that. I'm a lefty. Maybe that's why. But anyway, the correct answer is B, 148. So you guys have to know your potassium. You guys have to know your sodium level, which is 135 to 145. Okay. So when a patient has a fever or they're sweating a lot, or maybe they're exhibiting signs of dehydration. For whatever reason, that patient's dehydrated. What happens is the sodium gets concentrated because you're losing all the fluids. You lose all your fluids, your sodium gets concentrated. So you're going to see that sodium increase. Okay, so if I told you your sodium is 135 to 145, B is going to be your answer because you're going to see that sodium 148, which is increased. Let's look at our other choices. A, you have sodium of 130. That's low. You don't expect to see a low sodium in a patient that's dehydrated or on their way to dehydration. You expect to see the sodium to be low in a patient that has too much fluid. So when the patient's in fluid overload, you expect to see the sodium low. And when the patient's in fluid deficit, you expect to see the sodium high because of the concentration. So that's why A is not the answer. Then you have choice C and D, and both of those are within the normal range. Remember, the sodium range is 135 to 145. And some books, guys, differ on the range, maybe by a point or two for sodium, but that's the general range. For testing purposes, if they ask you about this, the number is going to be so out of whack, either you know it or you don't. It's not going to be like a point off. Next question. A client's brought to the ER stating that he had accidentally been taking 2 times his prescribed dose of warfarin, Coumadin. After observing that the client has no evidence of obvious bleeding, the nurse should do which of the following? A, draw a sample for activated partial thromboplastin time level. B, draw a sample for prothrombin time level and international normalized ratio. C, prepare to administer vitamin K. Or D, prepare to administer prothrombin sulfate. And guys, so the correct answer is B, draw sample. You want to do a PT-INR. So here's how I tell my students to remember it, and they seem to do pretty well with that. When it comes to Coumadin, it's going to be PT-INR. That's what you're going to check. And when it comes to heparin, it's going to be a PTT. And the way you can remember that, PTT, though you put those 2 T's together, kind of looks like an H, and that's what makes you think of heparin versus your PT-INR for Coumadin. So anyway, for this question, the correct answer is B. You're going to be doing a PT-INR because we're talking about Coumadin. Let's look at our other choices. So choice A, PTT, as I said, that's going to be for heparin. Choice C, vitamin K. Guess what? Vitamin K is the antidote for Coumadin. All right. So if a patient gets too much Coumadin, they're at toxic levels, and you need to give them the antidote. That's the antidote, vitamin K. And of course, choice D, prothrombin sulfate. Prothrombin sulfate is the antidote for heparin. All right. And I know some of you students wanted to choose C as the answer. Oh, let's give them the antidote. Why would you give a patient an antidote if you haven't assessed yet to see what their number is? What if that patient's confused? They think they've been taking 2.5 times the amount that was prescribed, and then you check and it's normal, right? So then you gave this patient the antidote for no reason. So remember, guys, you always want to assess before you intervene. ADPIE. A assessment always comes before the I intervention. Next question. A male client with AFibs receiving maintenance therapy on Coumadin has a prothrombin time of 37 seconds. Based on the result, the nurse will follow which of the following doctor's order? A, administer the next dose of warfarin. 2, increase the next dose of warfarin. 3, decrease the next dose of warfarin. D, withhold the next dose of warfarin. And so the correct answer, guys, you're going to withhold that warfarin. Your normal time in seconds is about 9.5 to 11.5. The numbers may vary just a little bit depending on the textbook that you're using. But guys, anybody that's on therapy, you want to see that number 1.5 to 2 times, which means doubled, okay? And obviously this patient's getting therapy, so you want to see that number about 1.5 to twice that amount. So let's go back to these choices. A, administer the next dose of warfarin. Well, I just told you that the normal number is about 9 to 11.5 for anybody, any normal person who's not on any therapy. If they're on therapy, you expect to see that number multiplied by 1.5 to 2. So if their number is 37 seconds, that's too high. So you are not going to give the next dose. That is too high. Let's go to choice number 2. Increase the dose of warfarin. Absolutely not. Didn't I just tell you that number was too high? So we're not going to do that. Decrease the dose. Guess what? You can't play doctor. If something was ordered, either you give it or you don't. Okay? So we're not going to do C as well. You're going to do D. You're not going to give the medication. You're going to hold the medication, call up the doctor, say, hey, you know, this is what you ordered. This is the time I withheld the medication. What do you want to do? Make sure you guys know, it's important you guys have to know that PTINR is for Coumadin, PTT is for heparin. You have to know the antidotes, vitamin K for Coumadin, protamine sulfate for heparin, and you have to know your numbers for both Coumadin and heparin. Next question. A nurse is handling a pregnant client who is prescribed to have an alpha-fetoprotein level. The nurse should explain to the client that this blood test, A, can indicate lung disorders and neural tube defects. B, abnormal levels are associated with increased risk for chromosomal abnormalities. C, once the alpha-fetoprotein levels are abnormal, an amniocentesis will be ordered. D, an alpha-fetoprotein is a definitive test for neural tube defects. And the correct answer is C. The alpha-fetoprotein, that test is, what's the word I'm looking for? It's a screening tool, okay? It's not definitive. It's not diagnostic. It does not say, yes, the patient has this. It's just a screening tool. Screening tools alert us that we need to test further and we need something definitive, right? So the screening tool, the alpha-fetoprotein, like I said, is screening tool, okay? And what's it screening for? Neural tube defect, okay? So if that comes back abnormal, then we're going to do an amniocentesis. Now, why? I know what you're thinking. Well, Professor D, why don't we just do an amniocentesis to begin? Well, remember, amniocentesis carries risks with it because it's invasive. Okay, you're actually puncturing that mommy's womb to pull out that amniotic fluid, right? So we really don't want to do that unless we have to. So C is the correct answer. We're going to do the alpha-fetoprotein, comes back abnormal. Then we'll do the amniocentesis, and the amniocentesis is what confirms. All right. Let's look at our other choices. A, it can indicate lung disorders and neural tube defects. Wrong. Wrong. It's a screening tool for neural tube defects, but it's not diagnostic. It's screening. So that's wrong. Does it tell you anything about the lungs? 2, abnormal levels are associated with increased risk for chromosome abnormalities. No, it's a screening tool for what? Neural tube defects. Then we have D, alpha-fetoprotein is a definitive. You already know that's not true. What's the definitive test? The amniocentesis. The alpha-fetoprotein, again, is just the screening tool. And if it comes back positive, it comes back abnormal, then we'll do the definitive test, which is the amniocentesis. Next question. An adult male client has a hemoglobin count of 12.5. Based on the result, the client is most likely having this due to which of the following noted in the client's record? A, emphysema. B, client living at a high altitude. C, dehydration. D, history of an enlarged spleen. The correct answer is D, history of an enlarged spleen. This is what's called splenomegaly. When patients have this, guys, it decreases the number of WBCs, platelets, and RBCs. What's inside of the RBCs? Hemoglobin. So we would see the hemoglobin go down in this type of patient. Let's look at our other choices. A, emphysema, and B, living high altitude. Actually, guys, that would make the RBCs go up. Why? Your body compensates. Your body's like a machine that has been programmed to survive no matter what. So being in those high altitudes, having emphysema, what happens is your bone marrow produces a whole bunch more RBCs than normal. Why? Because in the RBCs, hemoglobin. What does hemoglobin carry? Oxygen, right? So in those two conditions, you'd see the RBCs, which means you see the hemoglobin go up because the body's trying to compensate. C, dehydration. Patient that has dehydration, we may see the hemoglobin go up, and that's only because it gets what? Concentrated, okay? So the patient's dehydrated, hemoglobin might be normal, hemoglobin might go up, and the only reason it may go up is because it's concentrated. So the correct answer is D, enlarged spleen. A screen test for detection of HIV reveals a positive ELISA exam. Which of the following tests will be used to confirm the diagnosis of HIV? A, indirect immunofluorescence assay. B, CD4 to CD8 ratio. C, radioimmunoprecipitation assay, that's the RIPA test. Or D, P24 antigen assay. And guys, the correct answer is A, your IFA. So guys, this test, the IFA, you really don't hear about it that much, but I'll tell you the other test that you hear about it a lot, you read about it a lot. This is a concept important for you to know, the Western blot. So this IFA and the Western blot, those are the two confirmatory tests. Diagnostic, they let you know, yes, this patient is HIV positive. Why? Because it tests for the antibodies. Okay, so let's look at our other choices. B, the CD4 to CD8 ratio. This shows you the progression of the disease, how bad it's getting. So for example, it shows you the numbers. So that really does not show you the antibodies. It's not diagnostic. It just shows you the progression of the disease, okay? Then you have your RIPA test. The RIPA test, it looks for the HIV protein, not the antibody. And then you have the P24 antigen assay. Again, this just shows for that protein, but not the antibody, okay? So that's why your correct answer is the IFA and the Western blot. And Western blot is usually what I see given as a choice for test question. The client went to the emergency room with a sudden onset of chest pain and difficulty of breathing. Which of the following result is indicative that the client's experiencing a myocardial infarction? A, myoglobin level of 98. B, troponin T of 0.09. C, troponin 1 of 0.5. Or D, creatinine kinase, that's your CKMB of 155. The correct answer, guys, is A, your myoglobin of 98. The myoglobin should never be more than 90, okay? So more than 90, that's showing that there's death in the muscle of the heart. You know, that's what your heart is. It's a big muscle, right? So myoglobin of more than 90 is showing that that heart muscle has been injured. Choices B, C, and D are all within normal range. Now, there's one more thing you guys need to know. You see choice C, the troponin 1? If you guys ever get a question asking you which lab test is most specific for myocardial infarction or injury to the heart, that's it, your troponin 1. And I've seen that question pop up a lot of times. So make sure out of the CKMB, the troponins, you have your troponin T, your troponin 1 or troponin I. It's the troponin, I call it troponin 1, but guys, you know me by now. Anyway, that's it. That's the one that's most specific, okay? Because the other ones, Yes, it tells you about the heart, but they can be elevated in other circumstances. I won't go into detail on this video, but that troponin 1 is only for injury of the heart layer, heart muscle, okay? Next question. A nurse is caring for a client with diarrhea and dehydration. The nurse determines that the client has received adequate fluid replacement if the BUN decreases to A, 36, B, 27, C, 18, or D, 6. The correct answer is C, 18. Okay, guys, so blood, I can never say it. Blood, urea, nitrogen. That's what we look at when we want to see kidney function, what's going on with the kidneys. Are we getting good perfusion or not? We know that kidney function is the kidneys getting better when we see the BUN start to drop, because whenever the kidney's in trouble, BUN and creatinine go up, right? Once the patient starts to get better, it starts to go back down. So that's why C is the correct answer. And you wouldn't know this unless you knew your BUN level, which is 7 to 20. Some books say 7 to 22, depending on the textbook you're using, but that's around the range, about 7 to 20. So when you see it go back down to 18, you know the kidneys are getting better. 36 is way too high, 27 is way too high, and 6 is low. So 18 is perfect. It's right within the range that you'd like to see. A client with diabetes mellitus has a glycosylated hemoglobin A1C level of 10%. Based on the result, the nurse plans to teach the client about the importance of A, maintaining the result, B, preventing hypoglycemia, C, preventing hyperglycemia, D, avoiding infection. Now, guys, the correct answer is C, preventing hyperglycemia. So for the normal lay person that's not diabetic, you want the hemoglobin A1C to be less than 5.7. Some books say 5.7 or less. So around there, 5.7 or less than 5.7. But if that patient's diabetic, you want it to be less than 7. Okay, so 10 is way too high. Some books say 7.5, so it just depends on your textbook. But 10 is way too high. Let me tell you about this hemoglobin A1C. That lets you know how controlled the patient's blood sugar has been doing over the past 3 months, 90 days. Why is this important? Because patients like to trick you. So they know they're coming into the office, they're going to get their blood drawn. So the day before, they eat really well. All they eat are salads and drink water, no juice, because they want to go in, get their blood sugars, and the doctor say, "Oh, good job." No. With the hemoglobin A1C, they can't trick you. Even if they diet a day or two before the test, it gives us an accurate picture. It gives us a 90-day snapshot of what their blood sugar has been looking like. So that really lets you know if the patient has been compliant or not. Okay, so a couple things to take away from this question. Hemoglobin A1C, 90 days, gives you 3 months snapshot of how well that patient's blood sugar has been controlled if they've been compliant. For patients who are not diabetic, you want it to be 5.7 or less. Patients who are diabetic, you want it to be 7 or less. Was that my second or third point? I don't remember. I just kept talking, but you got it. Next question. The nurse is reviewing the lab results of a client receiving digoxin and notes that the result is 2.5. The nurse plans to do which of the following? A, give the next dose. B, notify the doctor. C, check the client's pulse rate. Or D, increase the next dose as ordered. So before you can answer this question, you have to know what the normal range for a dig is. Okay, so digoxin, your normal range is 0.5 to 2. That's your normal range. This patient is at 2.5. And remember how when I was talking to you about potassium, I talked to you about narrow therapeutic range? Digoxin is one of those meds that have a narrow therapeutic range, so it's very easy for that patient to go into toxicity. So if I just told you that range is 0.5 to 2, and this patient's at 2.5, they're at what? Toxicity. So are you going to give that med? No. You're going to hold it, and you're going to call the doctor. You are not going to give that med. All right, last question. A nurse is reviewing the CBC of a child who's been diagnosed with idiopathic thrombocytopenic purpura. Which of the following lab results should the nurse report immediately to the physician? A, platelet of 30,000, B, hemoglobin of 7.5, C, reticulocyte of 6.5, or D, eosinophil count of 700. And the correct answer is hemoglobin of 7.5. So let's go back to the question. You have to know what idiopathic thrombocytopenic purpura is. Whenever you see something say idiopathic, that means we don't know why they have it. They have it, we don't know why. All right, so idiopathic. Thrombocytopenic, let's break that word down. Thrombo means clots, right? A thrombus. Cytopenic. Penia means a little bit of. So the patient has a little bit of clotting factors. What does that mean? The patient's at risk for what? Bleeding. That's what it means, right? They're at risk for bleeding. So it says, which lab value are you going to report to the physician immediately? And the correct answer, guys, is your hemoglobin of 7.5. That is extremely low. That child has a hemoglobin of 7.5. They're bleeding somewhere. I don't know if it's in the stool. I don't know if you're going to see it in the urine. They're hemorrhaging out somewhere. They are bleeding. That hemoglobin is way too low. For a child, you expect the hemoglobin to be at least, depending on the child, if it's like a toddler, you can get away with a 10.5. It's an older child. You want it to be at least 11, right? 11.5. But this child is at 7.5. No, they're bleeding somewhere. So you're going to notify the physician immediately. Guys, I hope that this video was helpful to you. If you guys would like to see more questions on lab values, just let me know and I'll find some more concepts that I know tend to pop up on NCLEX, ATI, HESI, quizzes, midterm, you know, name it. I'll look for some for you and I'll make another video. If you haven't done so already, guys, please don't forget, like, comment, and subscribe below, and I'll see you next time.